Kia ora koutou, no mai haere mai to tonight's webinar on optimizing hormone therapy, the role of transdermal estrogen gel. My name is Katie McCulloch. I'm a nurse practitioner working in Tamaki Makaurau, and this webinar is kindly supported by Whānau, who recognises the importance of sharing information, education, and support to our clinicians. This webinar will cover transdermal estrogen applications, reviewing indications and exploring the broader role of female hormones, while highlighting the importance of expanded options for Aotearoa New Zealand. Dr. Sam Newman will discuss various estrogen therapy options, and the session will also address the need for evidence-based education, supporting healthcare professionals and setting realistic expectations and ensuring optimal treatment outcomes. Our speaker tonight is Dr. Samantha Newman. She's a general practitioner, honorary lecturer at the University of Auckland, an adjunct research associate at the University of Monash, and Sam established Female GP in 2016 to improve access to focused healthcare for women. She works as a forensic medical examiner for sexual assault and in general practice at a local family practice. Over to you, Sam.
Kia ora, and thanks, Katie, and thank you for the lovely introduction. So I'm going to talk about optimizing menopause hormone therapy and the role of transdermal estrogen. I'm going to make a bit of an apology to start. So I'm in Napier and the power went out. So I had to make a speedy dash across Napier and to a friend's house. So hopefully the sound and the video and everything's okay. So who am I? I'm a GP and I spend a lot of time doing women's health. And for me, these two are inseparable. I have set up an online education program. And also I think, being a GP and in women's health, we also have an innate interest in it through sport and through our social day-to-day activities. Pharmac kindly supported this presentation, but they didn't have any input into the design and into the content. So today, I'm going to aim to go through how you can confidently prescribe hormone therapy. And I think to be able to understand that, we need to know why we're prescribing it. And that's going to be a key focus of this presentation. We want to do no harm and we need to do the risks, but we really need to know what the benefits we're going to achieve through it. And how we're going to optimize it is we're going to focus on the skills for we're going to go estrogen and talk about what does it do, what to expect, and focus on this in a patient-centered way using personalized medicine, evidence-based practice, and how we can use technology and investigations where possible. I'm going to allude to the fact that actually it would be amazing if we had a multidisciplinary network to work together with in this space. And I'm going to talk a little bit about monitoring and follow-up, because obviously it's a journey and we need to set our patients up to succeed. I don't think it's typical to start with the controversies, but actually hormone therapy and menopause is it's full of it. Even the indications, the duration of treatment, the type of treatment, the dose of treatment. And then there's this huge explosion on social media about what it does, who should have it, who shouldn't have it, and almost polar ends of the spectrum. So what I'm going to try and do today is I'm going to try and go back to the science, back to the basics, and look at the patient in the center. And then you can work through with your patient what these controversies mean and the impact hormone replacement therapy could have for benefit and also for risk. So I'm going to do this through a case, and we're going to talk about Aria. She's a 47-year-old Wahine Māori, and she's a teacher. She has 4 children. She came in to general GP saying, please can I have sleeping tablets, and please can I stop my patches? So first of all, it's about understanding Aria. Why is she here now? Through the dashboard in my GP practice, I can tell that she's fit and well. She drinks a small amount of alcohol, but actually she doesn't really come in very often. She had a Meihana inserted a couple of years ago for heavy periods, and she's currently on an estradiol patch of 50, so a medium dose, but it was last prescribed in May 2024, and it's now November. So actually, that's a living red flag to me is she taking it? I want to know why Aria has come in now. Why does she want sleeping tablets? And why does she want to stop her patches? And particularly, and this is where I think, one of the controversies will come about straight away, and how I may challenge some of your thoughts tonight, is that for me, somebody who's had sleep disturbance in midlife and is asking for sleeping tablets, that's hormones until proven otherwise. But with Aria, we need to make a connection. We need to build a relationship and find out actually what's important to her and how we can move her health forward. Finding a bit more about her, she has recently moved house, and it's quite tough at home. It's a smaller house. They didn't want to move. She actually looks quite uncomfortable when I'm talking about the patches, and I just get the impression that the application and things are just a bit tricky. She's really busy with work and under a lot of pressure, both financially and time-wise. She really loves netball, but recently she hasn't been playing it as much. So through understanding her, we are looking at her as a whole, and we're all familiar with the concept of Te Whare Tapa with Sir Mason Jury. And now looking at it from a slightly different lens is through a hormone lens. So as I said just prior, whenever I see someone in midlife, a female with sleep disturbance, I immediately think hormones. So going back to her recent reproductive hormone history, she's had 4 children and postnatal depression with her last. And that was at 40 years of age. In 2021, she had a Meihana inserted for menorrhagia. A year after, she changed her job. And she actually was a deputy principal and stepped to a different role as a head of year at a much smaller school. In 2022, I noted that there was vasomotor symptoms, so hot flushes. And for most people, that's a straight indication of hormones. And then in 2023, she started estradiol patches at 25 micrograms, so a low dose, and now she's on 50 micrograms. And as we noticed, she hasn't come in recently for the patches. And also going through the notes, I couldn't really elicit what else was going on at that time. So what I realized through my practice of menopause and hormones is that there is an intricate, inseparable relationship between physical health and mental health. And actually, estrogen impacts the brain and many other aspects of cognitive well-being. And when I was looking about ways to develop my understanding of psychological well-being, I came across the Meihana model. So this was developed by Professor Pitama, and was developed for use to support Māori in mental health. And what it does is it highlights aspects that are specifically relevant to Māori to help with the relationship and to formulate an appropriate management plan. And through looking at this, it made me reflect on cases like Aria's and actually how it's really important to look through just the medication and understand what's going on for the individual. So the Meihana model includes physical health, psychological health, about the whānau, and also spirituality. One of the things that it talks about with spirituality, and it acknowledges that as practitioners, this can be quite hard for us to talk about and know our role in this space, but about building attachment and a safe place where the individual feels comfortable and able to work with their health. It then talks us also about the environment and the wider society. So if we then think about Aria. And I just want to make a note here. I'm not professing to be an expert on the Meihana model. I'm just looking at different ways of increasing application through menopause and how we can improve and optimize patient care. So Aria said, I am not myself. And there's a paper that looked at symptoms and well-being in perimenopause and menopause, and one of the biggest comments that women say is, I am not myself. So much like central crushing chest pain is a red flag for an MI, for me, I am not myself makes me think, is it hormones? So as I said at the beginning, I was going in with a bias thinking, how can I help Aria? I wonder if it's hormones. And this is another clue to indicate to me. Looking at her physical health, so she had a Meihana for menorrhagia. We know menorrhagia, so change in menstrual flow, is very common in perimenopause. Hot flushes are the most common symptom. And something that I'll share with you is injuries. So I don't know if you've seen midlife women come in a lot more frequently with injuries and body pains, but actually, a lot of the time, I find there's an association with pain, and injuries get better with hormone therapy. So looking at it from a slightly different perspective, and it's out of this scope to talk about the direct relationship, but I just want to sow that seed. The other thing with injuries is thinking about actually what do the injuries prevent someone doing. Teaching is a pretty physical job. And also she loves netball and that fills her cup. So if she's got injuries, then it may prevent her from doing what she needs. And we also know the benefits of exercise. With respect to her psychological health, Aria reported that she was irritable, she was feeling angry, she wasn't sleeping well. And that's probably since the birth of her fourth child. And she just doesn't have any motivation. And that was one of the things, as well as a loss of confidence, that led her to leave her previous job. There's a term called reproductive depression and perimenopause depression, and I'll come on to it in the following slides. But these are key features of this concept of decreased psychological well-being. And then moving on to whānau. So we know that depression in whānau members can make it more challenging. What with being the sandwich generation, so if children may have some challenges with things like ADHD, and we also know women with ADHD have a more challenging experience at perimenopause too. And then what is the involvement with her whānau? Does she want them to be here? Often that's the case, but people don't feel that they're welcomed into this space. So finding out what matters to her. So going back to her story, she's moved house, so her whānau has changed, her roots. She doesn't feel comfortable there anymore. And she's moved further away from the practice. So coming to the practice is a real challenge, what with work and having to prioritize things, and money's really tight. And what with the patch supply, it was even more challenging ensuring a stable medication. So that's why she wanted to stop it. This is a little bit more about perimenopause depression, and we'll build on why it's so important to look at mental health in this space. So her age, mood changes often occur a few years prior to the physical symptoms of menopause. So being in her late 40s now, and potentially symptoms started a few years ago, then actually this really aligns. We know that finances can impact mental health as well. A personal history of mental health challenges, such as depression, or in Aria's case, postnatal depression, family history, and her physical health. However, she's got protective factors. She loves her job. Her family are really supportive. And now I'm going to share with her about perimenopause depression, because I think that this can encourage her to feel empowered again, and enable her to make choices to improve her quality of life. She also loves netball, not just from the physical side of things, but the community it gives her and the support with her teammates. The really interesting thing is that these protective factors are challenged by the symptoms of perimenopause and menopause. So if she's got injuries and she's not sleeping well, and she's unable to do sport, then it's really going to threaten the protective factors. So once again, I think of looking at the protective factors and what we can do to support them as really important in managing perimenopause. So now a little bit more detail about through a hormonal lens. So with her first 3 children, she had no history of postnatal depression nor antenatal depression. At 40, she had her 4th son. And from then, a couple of years later, which isn't as typical as postnatal depression, that's when she was diagnosed. So I would be thinking, actually, is the postnatal depression really perimenopausal depression? Does it matter? Probably not if we can make her feel better, because it's the same management plan at this stage of life. Or the same medical management plan. She had a Meihana inserted for menorrhagia. And when we explored that with her, it all happened very quickly. She went to clinic for heavy periods and was told that she would have a Meihana and that would make things better. And that was it. She started hot flushes, but she was pretty vague about that. She said they didn't really bother her too much, and she's not really sure why it was written down. And then the year later, she started estrogen patches. And once again, she didn't really know why she was on them. So even when they increased and she wasn't noticing the benefit, why would you continue taking a medication that you don't know why you're on it? And I think this is a really common thing in hormonal health, particularly as your symptoms evolve along the way. So I say to Aria, I could talk to you for ages about your well-being and your symptoms, but what I'd really like to do is give you the knowledge that actually you can go away from this consultation today feeling that you understand yourself more, and why I would be suggesting that actually estrogen patches would be a really good thing to continue for you, and why I'm really sorry you're not sleeping, but I think that estrogen patches would help as well. So if you look at the menstrual cycle, and this is how I describe it to patients, at the beginning of the menstrual cycle, the hormones are low. And what we're going to do is we're going to focus particularly on estrogen, and that's the teal, the turquoise. And you can see it's low, and then it gradually rises, and it peaks mid-cycle at ovulation. And then it drops, and then it rises again and drops down again. After ovulation, so mid-cycle, progesterone rises. And the progesterone rise and drop is called the luteal phase. So the first part of the menstrual cycle is the follicular phase, and the second part is the luteal phase. And in the luteal phase, it's also known as the high hormone phase because there's a lot of change in the hormone levels. So therefore, in summary, over a 28-day period, the hormone estrogen is going up and down twice. That's a lot of change. And then progesterone is going up and down for 2 weeks as well. So what does this mean, and what's the significance? So in the perimenopause, this is how I describe it to my patients. So every month, the brain is telling the ovaries to release an egg, and that's the FSH. So FSH is telling the ovary to release estrogen, but the ovary is a little bit tired. So it needs a bigger signal. And this is why the FSH rises. And then eventually the ovary kicks in and shouts really loud, because estrogen is a pretty amazing hormone. And actually, estrogen peaks even higher than it does at puberty. And then it drops. And then it rises again. So there's 2 even bigger peaks. And then from our mid-30s onwards, progesterone is dropping. And this often brings back memories for those who have had fertility challenges. So in the perimenopause, you've got even higher estrogen and dropping progesterone. But what does this mean to an individual? So I have this diagram on my wall, and these infographics are available if you would find them helpful for your practice on my website to download. And I've actually got them printed off and laminated and have whiteboard markers. So I draw on them every day because I was going through so much paper. But actually, if you show somebody, I think, this picture, and you say, this is where there are estrogen receptors in the body. So if every 2 weeks your hormones, the driving factors are changing, then it makes sense that you have a different experience in your body. And then when in the perimenopause, these signals are changing even more, and variably, it's understandable that you can lose a sense of control and not know where you're at. So this infographic shows that the peak of estrogen at puberty is here, and the peak at perimenopause is here. So you can see how it's much higher. And then overall, estrogen does drop, but you can see it's a bit of a rocky road. And it's often these changes in hormones that really lead to more symptoms than even at the menopause. So what does this mean for her? So often I use something called the Green Climacteric Score, and that's a list of symptoms, and that helps me prioritize and with a patient acknowledge their symptoms, and also as a bit of a monitoring plan moving forward. But I think the biggest thing is that I can say, I believe you, and this is why it's really hard for you right now. So Aria doesn't have a period because she has a Meihana in. And so therefore, we don't know where she is in the cycle. So if we go back to this slide here, you can tell if someone's having a period that after the period, hormones are a bit lower and generally they feel well here. But actually, with Aria not having a period, that also can further perpetuate the sense of loss of control because you don't know where you are. So we need to make a plan, I say, because there's things that we can do to make you feel better. And actually, the best thing to help perimenopause, mood, and hot flushes is hormone replacement therapy. And if we look back at Aria's journey, and she was given medications that she didn't understand why she was given them, well, it makes sense that when she was had barriers to collect them, that at some point it would probably just be too much. So in the short term, as we talked about perimenopause, we're supporting the changing hormones. In the long term, it's improving chronic disease associated with low estrogen. And we can positively say that estrogen therapy improves mood disorders and hot flushes in over 80 to 90%. And I also see it improving sleep, joint pains, urinary symptoms, libido, and much more. Once again, focusing on what our patients' concerns are and most and symptoms that affect them most to really explain to them what the benefits could be. I also often look at a family history here because a lot of people are worried about the risk of their chronic illnesses based on their whānau. And Aria didn't voice anything to me, but if she had a family history of type 2 diabetes or bowel cancer, and we can say this would actually further, and this would reduce the risk of developing these conditions. But overall, starting hormone therapy within the perimenopause actually increases life expectancy by 2 years. But what is hormone replacement therapy? So menopause hormone therapy was formerly known as hormone replacement therapy. And for most people, it consists of 2 hormones, estrogen and progestogens. What I'm not going to do today is tell you the doses and how to prescribe it. What I want to do is leave you with concepts and how to work with your patients through what I've learned to be able to then signpost how to move forward. So estrogen is the main hormone that improves symptoms and is associated, as I said just prior, with decreasing health risks. Progestogens were previously used only for endometrial protection. However, there is now thought that actually one of the progestogens, utrogestan, can improve symptoms and sleep as well. So estrogen in the perimenopause, we are buffering changing hormones. Estrogen is a low dose and the hormone, as part of hormone therapy, it's low. And so we're buffering, we're still getting these ups and the downs. But over time, the estrogen receptors I described become saturated. And so women generally, their bodies are not so affected by these huge changes. And then in postmenopause, estrogen is low, and that's when we are literally replacing the estrogen. And we need a progestogen because estrogen stimulates the endometrium. And if we then think back to Aria, who had heavier periods early on in her perimenopause, this is a sign that her estrogen levels are potentially higher and her progesterone was dropping. And if we have an appropriate dose of progestogen in comparison to the estrogen, then actually we don't get an unhealthy endometrial lining, and it even decreases the risk of endometrial cancer. So Aria has got a Meihana in situ, so we don't need an additional progestogen. So, however, I think I'm just going to briefly say about how to use progestogens. So progestogen is the class of medications. In this class, there are broadly speaking 2 types, synthetic progestins and the body identical utrogestan. So progestins were developed in the 1970s purely to protect the lining of the womb. So they aren't as physiological as the natural progesterone, which is utrogestan. Utrogestan is more physiological, but it's not as good at controlling heavy menstrual bleeding. And if we think that progesterone in our body, endogenous progesterone, is released in the luteal phase, then it makes sense that we want to give progesterone in the luteal phase in the perimenopause, because it supports the endometrium here. And when it drops in line with our body, then that triggers menstruation. So what would Aria like to do? Would she now like to continue estrogen therapy? She says she'd like to, because actually she now sees the benefit in what it could do for her health. So there are, broadly speaking, 4 options of estrogen treatment. There's patches and gels, which are both transdermal, so absorbed through the skin, oral estrogen, and we mustn't forget about the contraceptive pills, which are actually quite useful in perimenopause, but it's beyond the scope of this presentation today. So why is transdermal estrogen so good? Well, this is because it's got no increased risk of blood clots. Because it is absorbed through the skin, it is not metabolized through the liver, so we don't get increased clotting factors. It therefore means it doesn't increase blood pressure, and it doesn't worsen the cholesterol profile either. The preparations of transdermal estrogen, we have estradiol, which is a body identical preparation. And the aim is that it improves well-being, and both of these options are now funded. There are situations, and this is a good reference here, where transdermal therapy is recommended. And we're going to focus on the individual preference, but in these other cases, it is recommended for transdermal over oral. So whenever we're prescribing a medication, we need to know the risks, and we need to explain to our patients what they may expect from a side effect perspective when taking a new medication. So I stole this classification from Dr. Louise Newson, a incredible menopause medic from the UK. So she says the possible side effects within the first 3 months: bleeding, blues, bloating, and breast tenderness. And so that's what I say to my patients. Bleeding is more common in the first 3 months, and even more so the closer to your final menstrual period. Some people feel a bit down or have some anxiety, but this generally settles. Bloating can occur, and once again, that usually settles, and the same as breast tenderness. We want to minimize these side effects, and we can do that by starting low and increasing the dose slowly. What other risks and considerations do we need to be aware of? Well, with respect to cardiovascular disease, actually the risk is dependent on the baseline risk and the type of estrogen and progestin at the age of initiation. However, in relation to Aria, she is fit and healthy and in her 40s. So overall, actually, HRT is going to decrease her risk of cardiovascular disease. And similarly with venous thromboembolism, she's got no risk, and actually transdermal doesn't further increase the risk, and so we can safely prescribe it. So I've got this slide, and it's not pretty because it's sad that we keep coming back to the Women's Health Initiative, the study in 2022 that, as Robert Langer said, the incorrect interpretation has started a fire which keeps on going. So this study put the majority of women and doctors, understandably, off HRT, as they were told that HRT increases the risk of cardiovascular disease and breast cancer. So if you're told that, you're not going to want to prescribe it. However, the average age of these women was 63, the average BMI 28, a third had existing cardiovascular disease. The medications prescribed were not the body identical options that we use in preference now. And estrogen-only hormone therapy, on further analysis, actually was statistically significant in reducing the risk of breast cancer. Sorry about the typing error. So that says there's much more to estrogen and breast cancer if estrogen-only hormone therapy reduced the risk of breast cancer. So we can confidently reassure Aria. And why I often highlight this is because when my patients go home, and if they've got a whānau or friends that talk to them about the worries, then I want my patients to know why and to be able to feel confident in the medications we have prescribed in clinic. There are some other risks to be aware of, and obviously this presentation is going to be available for after, so I'm not going to dwell on this too much, but meningiomas can be hormone receptor positive. There are some other risks of other cancers, but overall it's about, looking at figuring out what's important to your patient and how that could impact them. So one slide here about hormone therapy and breast cancer. Combined therapy does increase the risk of breast cancer when taken for 5 years or more by 4 out of 1,000. However, if we put this into context, having 2 alcoholic drinks a day or being obese increases rates of breast cancer more than that. And if we do 2.5 hours of moderate exercise a week, this decreases rates of breast cancer by 7 cases fewer per 1,000. So once again, there's a much bigger case to look at when we look at optimizing well-being and hormone therapy for our individuals. So it's also really important to set expectations. One, because if we think an individual has got symptoms we want to improve, we want to make sure we're getting there and that they're working, and also that we're not missing anything else. So when starting medication, I often ensure that logistically there's no questions and talk about the side effects. Generally do a follow-up at 3 to 6 weeks, depending on the individual and what else is going on in their world at the moment. Then at 3 months and 6 months, and then often you can do a 12-month review. At each step, you're reviewing the side effects, you're ensuring that there's no unscheduled menstrual bleeding, because that does require investigation, particularly after 6 months. And I always sow the seed of a life plan, because a lot of people are worried that they're putting off menopause or that it's addictive, or they feel so great and they don't want to stop it. So going back to the controversies I highlighted right at the beginning, well, a lot of the guidelines still say that hormone therapy should be prescribed at the lowest dose for the shortest amount of time. So as clinicians following these guidelines, it puts us in a really tricky situation. However, that's actually a myth now. And as long as the benefits are outweighing the risk for your patients and your patients are well, then you do not need to discontinue it. And there is no age at which hormone therapy needs to be discontinued. However, I do find that I can often decrease the doses, and women who were on oral because of absorption issues, and we will talk about that, changing them to transdermal often gives appropriate symptom control. I just took copies of their guidelines from MedSafe and the New Zealand formulary, both of which say hormone therapy should only be prescribed for estrogen deficiency symptoms in postmenopausal women. So as doctors, where does that leave us? Well, the international, worldwide, it is recommended and appropriate to prescribe hormone therapy in the perimenopause. But I think that whenever I'm doing education sessions, both in community and to healthcare professionals, I'm always setting the audience up that we need to understand and work together to move this space forward, because it's a really hard space for all of us to be in. And no wonder we're confused. And I say that about healthcare professionals too, because actually fundamentally we want to do our best and we want the best outcome for our patients. So going back to Aria, what were her priorities? Well, she wanted to feel better and to sleep. And so, thinking, what does she need to achieve these goals for what she came into the clinic? Fundamentally, I think it comes down to trust. And that's how we need to optimize hormone replacement therapy in menopause the most. She needs to understand and feel safe with medications and with understanding what's going on with her body and her mind at this stage in life. She needs to feel supported, and that, I think, is needs to be with the wider team in the practice and in the community. Her whānau also, we want to get them on board and get them working with her. She wants to be able to work, and that's really important for her. 1 in 10 women stop working due to menopause, and we know the negative health consequences that has. And she's really time poor. So we need to make this as easy as possible for her. So we decide to proceed with a prescription. What do we go for, a patch or a gel? Fundamentally, it's patient preference. But with Aria right now, she found that she just didn't like the patches. She didn't like having them in her body. It didn't feel right to her. And also, I would then be saying to her, well, from my perspective, with the symptoms you're experiencing, I don't think you're on a dose to help manage your symptoms. So I'd be wanting to, think of a way to support her better. There's slightly increased irritations with patches from the adhesive. It is really handy with patches. You change them twice a week, fit and forget. It is a slow titration, but some people do get these quite marked peaks and troughs with them. And an issue is when the patches don't stick or when they're crinkly. And different people do absorb the patches differently. With respect to the gels, individuals can still experience skin irritation, but it is less likely than the patch. The gel obviously won't fall off. There is a risk of transfer, so you're recommended to clothe afterwards and not hug anyone for an hour. And currently, there's only one funded brand available in New Zealand. So Aria just decides to try estrogel. So estrogel comes in a bottle similar to this, and 1 pump is equivalent to a 25 microgram patch, but estrogel is administered daily. When you get a bottle, you need to prime it. So I tell patients to get a tissue and to press it 3 times, and that still leaves 64 pumps for remaining for her medication. The average dose, estrogel say, is 2 pumps, 50 micrograms. And this is a daily application. And it doesn't matter the time of day as long as it's consistent in the morning or in the evening. So how do you apply it? Well, after a bath or shower to clean, dry, healthy skin, you put the pump on your hand and then apply it to that outer arm from the shoulder to the wrist. And you spread it, you don't massage it into the skin, and then you wash your hands afterwards. After 5 minutes, cover with clothes to prevent transfer and wait 60 minutes before applying other creams. You can apply it to your outer arm, so from the shoulder to the wrist, or your inner thigh. Most people generally apply it to the arm. However, you can apply 1 pump to a body area, and absorption is greatest and best over a larger area. So this is why it's better to do, if you're on 4 pumps a day, either do 2 pumps morning and 2 pumps evening on the arms, or you can do 2 pumps on your arms, 1 each arm, and then 1 on each leg. For many women, estrogel is convenient, but I do find more with the lower doses. It may be more discreet for women than patches, depending on occupation and hobbies. Generally well tolerated, it's quick drying, it doesn't stain clothes, and it is odorless. And now it is funded. So what happened to Aria? So after 3 weeks, she started sleeping a bit better. And this is when we start to get stable levels. And after 12 weeks, she found her sleep was back to normal, once again reaffirming and helping build that trust in her relationship with me as the doctor. She was also having less body pain. She was able to play netball again, and she felt much better in her relationship. And so this is why these are stories I hear a lot, and I'm going to talk more about what we've seen in the community, but about how hormone treatment isn't just a lifestyle choice. So everybody knows, I think, that there was an estrogen patch shortage. And this is because the demand has just grown incredibly. This is due to many reasons, but I actually think it's because now we know it's safer, and we're also beginning to understand the impact of hormones even more. So one Saturday evening, I work weird hours anyway. I was doing a prescription, and I ended up ringing around pharmacies elsewhere in New Zealand for a patient that had taken us years to feel better in the perimenopause. And then I was like, why am I doing this? Because I was hearing through community members, friends, my patients and non-patients, and having multiple script requests for different pharmacies and different doses. And I was like, patients are really worried. Users of HRT are really worried. How can I share this? Because I see every day that hormone replacement therapy isn't just for hot flushes. So I made an advocacy survey with a friend at Massey University, and over 2 weeks, we had over 2,000 respondents. I wanted to get new data and novel information because everybody who has done surveys or looked at hormones in the past generally does a tick box. So I asked for free text of what symptoms improved the most, what surprised you. And 85% of people said that sleep improved. Hot flushes were really high up. But then if we look at, the rest of the symptoms, a lot of them are about cognitive and psychological well-being. Putting it out there, what happens if we treated insomnia with hormone replacement therapy in midlife? What impact would that have? And then I wanted to know the impact of the transdermal estrogen, because I thought, if people don't know the impact that this sleep disturbance and this body pain is having, then why would anybody make a change? You can see here that over 60%, 65% of people reported a negative impact on their physical health when they were unable to access their patches. And 80% found it had a negative impact on their emotional well-being. A lot of people, like 47%, I think it was, impacted their ability to work. And actually, 67% of doctors found, or 65% found it impacted their work ability. And 20% of teachers and nurses actually had to take time off of work. So I managed to present it at the IMS conference recently in Melbourne. And here's a few key take-home points. So patch brand does matter. 44% had worsened symptoms with patch brand changes. So this, to me, shows that there is so much more than just one medication and one size fits all, and that we need to learn together how we can optimize these medications. There's a black market for it. There was inequity for Maori and those who lived rurally. More challenges were faced. 60% required an extra GP appointment to a time poor group of individuals. Now we were having to give extra appointments. And there was a huge deficit in education and understanding in what estradiol users were given. So what can we tell our patients? Well, we can say when they didn't get better from estrogen and we thought it was hormonal, or that they couldn't get their patches or they forgot to change them, that we believe you. And every day I'm learning something new about a nuance of how something got better or worsened when something changed. We also know that we need to make it easy, and we need to figure out what is the benefit for them. So this is where it comes to optimization. We need to be delivering patient-centered care. We need to be able to work together more. We need to be able to follow up our patients, because this is a journey. And we need more evidence and guidelines to reassure regarding risks, and also how to optimize and change medication doses along the way. And I think we also need to be able to have improved technology to be able to advise, guide, and educate our patients so they can be empowered empowered and take control of their health. So we're almost done, but I'm just going to focus a little bit on absorption and why it matters. So if somebody doesn't absorb estrogen, then they're not going to get any improvement. So actually, often women then feel dismissed and a bit hopeless. So we need to be able to interpret this. So this is just an example case, 52-year-old lady on what is called high-dose estrogen patches and a Meihana. She's got symptoms of low estrogen still, hot flushes, joint pains, low mood. So what am I thinking? Well, I'm like, is it actually menopause? Do I need to be thinking of other causes of her hot flushes? So we need to go back to the drawing board. We need to take a history. And why do I want to see if she's absorbing right? Because we know that if we get the optimal medication for an individual, it improves their quality of life. So if we go back to pharmacology, most vasomotor symptoms improve with 2 pumps or 50 micrograms within 3 to 6 or 12 weeks. So if she hasn't had this, we need to put our thinking caps on. Also, cognitive and pain symptoms often take longer. So once again, setting our patients up to succeed. If the hot flushes go at 2 weeks, but they're still not sleeping, we can reassure them that this is still part of the journey. So when we're looking at absorption, we want to make sure that the medication is being used appropriately. If they're having a menstrual cycle, I'm wondering, are they cyclical symptoms? Are they worse premenstrual at ovulation? If somebody's got a Meihana, obviously, we don't have that benchmark. And I want to know when moving forward, are the symptoms worse on a specific day of the patch? And then we want to do blood tests. So blood tests do have a role in hormone management. We want to take bloods on day 3 or 4 of a patch. So that's a trough level, or before the application of gel. And so if somebody is menstruating, then ideally we need to take them in the first part of the menstrual cycle, because this is when endogenous estrogen is low. So if we don't know if somebody's having periods or not, if they have a high estrogen level, then it's not telling us anything really, because it could be their own estrogen. But if it's a low level, then we know they're not absorbing. So what am I talking about with numbers? So I tried to put things together in a table here to make it a little bit easier. And in principle, if we look at the number 250 at the level, so picomoles per liter, then under 250, sorry, actually above 250, most women have symptom improvement. So if your level is less than 250, I'm thinking, are you absorbing? So at that point, I'd be thinking, okay, should we change the preparation, or do we need to increase the dose? Once again, now going back to the controversies. So if we're increasing the dose and somebody's on 100, that is off license. And I can really appreciate that this can make some people feel uncomfortable. However, if somebody's level is 350 and they've still got really marked hot flushes, then I definitely would be thinking about alternative diagnoses. I just want to sow the seed that often estradiol levels in mental health conditions need to be higher. But once again, need to talk and support each other if needing to achieve these levels. So what impacts absorption? So people aren't making it up. Hydrated skin increases the absorption, and we know skin dries as we get older. Patch crinkling or peeling, just general variability, ethnicity too, and interestingly, possible magnesium deficiency causes less absorption too. So what do we do in these cases? Well, can we switch the preparation, gel versus patch? We can consider oral, and it's beyond the scope of this presentation to talk about the safety profile of oral, but being quite generalist, it is pretty safe for most younger women with no other health conditions. And then about prescribing off license, which once again, I don't want to make anybody feel uncomfortable, but I think looking back at the science can be really helpful. And then a whole nother webinar probably needed for this, but do you increase the progesterone? Because we know increasing estrogen increases rates of endometrial thickening. But if you're not absorbing it, then do you need to increase it? So absorption matters because women say hormone therapy saved their life. So it's about optimization. It's about figuring out, putting on our being a detective, looking at well-being and looking at the health span rather than lifespan. And I think this just really highlights that women were genuinely worried about that when there were no patches. And this is why it's really amazing being able to have another opportunity. And I actually felt quite emotional when I prescribed my first estrogel that was funded. It was a really strange feeling being able to actually just genuinely offer someone estrogel and not have to worry about their impact of cost. So some of my lasting messages are, don't fix what isn't broken. So if somebody is really happy on a patch and really stable and it's working really well for them, don't switch them to the gel for the sake of it. Because actually generally patch supplies should be more stable now, and somebody may not absorb a gel. We've talked about that. And frequently asked questions. Can I use a gel and a patch? Well, why not? Particularly if you're staying below the dose. So if you are on 100 microgram patch, but you don't really like it or you don't absorb it that much, why can't you use a 50 patch and 2 pumps? Because 2 pumps are easier than 4 pumps. And can I switch between present preparations? Well, why not? But we need to remember what is optimal for you. And some people will not be able to switch between preparations, but others can. So it's really individual. So in summary, menopause is more than one day. Journey with your patients and look at what their needs are. And it's actually really enjoyable and a really rewarding space to work in. Optimization reduces side effects too. And overall, midlife women are really high users of healthcare. So if we can optimize their well-being, they're going to come and see us less. Learn with your patients. It's all in the history. And I think we need to all work together because as GPs, we are really good and trained in managing psychological well-being, mental health, and cardiovascular risk. And I believe this is what perimenopause and menopause are. And now we've got even more tools in our toolkit to help our community. So yeah, thank you very much. And I hope that was useful and we've got time for questions.
We sure do. Thank you so much, Sam. That was awesome. I really love hearing you speak and that's the feedback that they were getting in the questions as well. So we do have a few questions for you tonight. So how would you go about swapping from patches to the gel? Would you do a straight swap or would you do a combination if that was what was indicated?
I find it really tricky, and I actually literally talk to my patient and find about how they are. I've got some women who have been so sensitive to hormone changes over the years that, doing a straight swap actually is quite frightening for them as well. Whereas others may just want to crack on with it. One of the ways I support my older patients to change from oral to patches or now to gels is to do a bit of a switchover. So there's no science behind this, but I just think different people metabolize different preparations at different rates. So therefore, I tend to do a little bit of a switchover, just making sure I'm staying within that therapeutic window at all times. So maybe the end of a patch, put a pump on or go for half a patch for a week and add a pump on. But I think as long as you stay within that lower than the within the recommended licensed doses, then yeah, totally, I'd switch over slowly.
Okay, awesome, thank you. And are there benefits to cyclical estrogen compared with taking it continuously?
I think fundamentally why we prescribe cyclical is to decrease rates of irregular menstrual bleeding. There's potentially slightly less breast cancer risk if you're taking Utrogestan cyclically rather than continually, but that's that's not a reason to do it. Some people cannot tolerate the higher doses of Utrogestan which are needed from a cyclical preparation. And also some people can't tolerate or don't do as well with the changing doses. So in those women, actually, you know, doing it, a lower dose for a longer duration can be more beneficial. I often talk about kind of almost like short cycling and long cycling. So for women who may have heavier periods or feel better on Nutrigestan, I might start them on 200 at, say, day 5 of the cycle and continue it all the way through to 28 days. Because I find that tends to give a little bit more stability overall, rather than the traditional kind of 12 to 14 days just in the luteal phase.
Okay, awesome. Thank you. And someone just said that you mentioned how Nutrigestan is not as good for endometrial protection. So what's the current evidence for use of this in transdermal estrogen of 50 micrograms or more? So the Australian Menopause Society recommends the same Nutrigestan dose of 100 milligrams daily or 200 milligrams cyclical for those higher estrogen doses. Can you just...
Yes. I find this question really hard to answer because I don't actually agree with the guidelines. I think if you look at the astute meta-analysis, if you are giving 100 milligrams of Nutrigestan daily for high-dose estrogen, there are higher rates of abnormal menstrual bleeding and proliferative and disordered proliferative endometrium. So what do? Well, we talk to our patients. And actually, for those who really cannot tolerate 200 milligrams, I say, oh, it's okay. The guidelines have said that actually 100 is okay, but we're just going to keep a bit of a closer eye and awareness on your endometrium. And if you have any irregular bleeding, then I want to know really soon and have a lower threshold. I'll also then be thinking over time period, do I want to bring their estrogen down so they can then just take 100 milligrams of progesterone? So it's a safer balance. And then also, my women with higher risk factors, more risk factors for endometrial hyperplasia, so increased BMI, PCOS, history of anovulatory cycles, I will tend to suggest that they go on higher dose Nutrigestan for the higher doses because that does protect the endometrium more. And you can even go up to 300 milligrams for the 100 microgram doses too. So that's where it really is about optimization. And I think the guidelines are a little bit of a framework, and actually sticking to the guidelines when you're not sure and when you're navigating this is a really good, safe place to be. But just thinking a little bit laterally and being open to suggestions from patients can really give you the skills and the understanding to move it forward and be safe.
Awesome, thank you for that. There's a couple of questions that are just regarding the use of Meihana for endometrial protection whilst using estrogen replacement. Can you just touch base on that very quickly?
So I was a bit cheeky actually, and I just talked about Meihana all the way through the presentation. So because it to not muddy the waters as much. But yeah, so a Meihana is the best protection for the endometrium, and it's licensed for 5 years. So I tend to use it more in the perimenopause when there's more irregular bleeding and a greater impact of estrogen on the endometrium. But you can continue to use it. I think the eldest patient I ever put one in was in her 70s. I haven't put one in someone in their 80s yet. But the uterus does get smaller, so it does become more technically challenging, and the tissues are thinner, so there are higher risks of perforation. I also sometimes I'm quite like cheeky with patients, and I say, you know what, I really like it when you have a Meihana because I'm not going to worry about your endometrium as much, because it makes it easier medically for us if there's no periods and we know that they're getting a really good endometrial protection. The other thing is that, you know, a Meihana doesn't mean you don't ever get abnormal endometrial cells. So even if you have a Meihana and you have a change in bleeding pattern, then we do really need to look at, is this endometrium unhealthy? And we do need to investigate it.
Someone's just asking about, do we know why the corneal changes occur with estrogen initiation, as they've had several patients complain of blurred vision? Is this something you've encountered?
Yeah, I think that the blurred vision is more due to dry eye, and so the estrogen on the tear duct and the lacrimal duct, and there's also testosterone has a role of eye function as well, and dry eye, and there are, I can't remember on the muscles. there are either estrogen or progesterone receptors as well. There's a really good article, I can't remember, I read it a while ago, in either Maturitas or Climacteric on the eye in menopause. So you might want to, yeah, have a read of that.
Awesome, thank you. In terms of like history of DVT, is there any issues with the patches or the gel in that situation?
No, it doesn't increase rates of blood clots, and all the data is pretty consistent. I wouldn't go off license in those cases, definitely though, because I think when you go higher doses, there is increased rates of the estrone and the kind of the not as healthy estrogen production. So I would tend to stay at lower doses. And this is also why we don't need to stop estrogen pre-operative, transdermal estrogen, because it doesn't increase blood clots. So and that still says in the guidelines need to be stopped pre-operative.
And in your opinion, when would you use Ovestin over estrogen patches? So if you've got a patient with atrophy and dryness, Ovestin is prescribed, but then how do we balance out the flushes and other symptoms? They've mentioned that escitalopram can be used, but it can reduce libido and, you know, a bit of a catch-22 situation.
Why would you not use systemic estrogen? I think, you know, being really honest, like, and estrogen, it's safe, it's the best treatment, you're going to get the most efficacy, it improves all those symptoms. Do often use antidepressants in conjunction with that, or if somebody gets side effects from a higher dose or not optimally controlled, or would rather stay at a low dose. But there's no medic, unless that individual patient has contraindications, I wouldn't be recommending. I do find if somebody's got genitourinary syndrome of the menopause, that when I first start systemic estrogen, I often prescribe Ovestin at the same time, because I think it just helps with a little bit of a boost. But then ongoing, about 50% do continue with Ovestin and 50% don't. And the Mirena can be a bit drying as well. So really individual. But with Ovestin, it is about setting patients up to succeed, because it can take 3 months to saturate estrogen receptors with that booster course, and then twice a week. And in really marked vaginal dryness, it can take even up to 2 years. So really, like, it's why we want to get in early with vaginal dryness.
And you can continue taking them dual for, I guess, until the symptoms right. Awesome.
Yeah, absolutely. You can definitely take both, and 50% of people probably need both.
Right. Oh, that's interesting. And so in terms of patches regarding placement, does it matter where on the body the patch is placed in terms of the variability and absorption?
So generally it's umbilicus.
Right.
So lower abdomen, lower back, and upper thigh, upper outer thigh. I find some people with more abdominal adiposity absorb better on the lower back, and I think that really can impact absorption as well for some people. So I do tend to give it a go, particularly before we had gels. I would try changing the patch location prior to preparation.
Which of the transdermal estrogen types is better for women who swim regularly, for example?
Yeah, so they say the patches are fine. I think most people, they are. Heat can increase absorption. So if you've got someone who's a regular sauna or spa user, then actually that could be a really good opportunity for gels. I don't know. I mean, if you put the gel on after you've swum, that's probably what I would do. It shouldn't be a problem in that sense. So yeah, I think really just individual.
And does a person's BMI affect the absorption of either the gel or the patch?
I haven't found any data on that, to be honest. So yeah, I think it's really, really individual. Anyway, yeah.
Okay. And in terms of using other lotions or sunscreens with the gel,
yeah,
Is it preferred to use them before or after, or
After, so an hour after.
so no hugging or no sunscreen for an hour?
For an hour. And even if you there have been papers that have shown if you wash at 30 minutes, there's less absorption of the gel. So that's a really important point. And I think, you know, some people actually, obviously I haven't got that breadth of experience in New Zealand with the preparations, but talking to colleagues, some people would use patches in the winter and gels in the summer, because it's just, you know, you're not having to stand there with nothing on in the freezing cold then.
Definitely something to consider.
Yeah, and I think so. I think it's really cool though, if you don't have an impact in your symptom change going away, you can just change preparation if it's more convenient for you. I think that's a really cool thing to know.
Okay, and there's quite a few questions regarding the safety of HRT in the perimenopause, particularly in younger, sort of early 40s, late 30s, early 40s. I think there's a sort of an increasing awareness of MHT, and that people are getting quite a lot of questions from those younger cohorts, just in terms of safety, in terms of length of use of MHT. Maybe just to talk a wee bit around that.
We don't know, but I definitely think that it's underdiagnosed. So look at, you know, rates of mental health in women, rates of fibromyalgia, rates of insomnia. How many women have been misdiagnosed that we're now realizing could be hormonal? And what are the impacts of these, you know, the antidepressants, the mood stabilizers, antipsychotics, sleeping tablets on well-being for health risks? Also, if we're then thinking about body pains, I've had patients that we've decreased the methotrexate doses down because their inflammatory joint disease got worse at perimenopause. And once we started HRT, everything was better. So I think this is where you've really got to look at the patient as a whole and try it, because it's pretty incredible when you see someone in their late 30s or early 40s and they say, you've changed my life. You know, we'd give a pill. We'd give the hormone pill if someone had awful periods, or for a teenager or someone in the 20s, we'd give a pill and say, here you go, this will make you feel better. So we need to go back to looking at our patient and asking them and finding out, why do you think this is hormonal? You know, what's your history been? Have you had postnatal depression? Did you feel amazing or awful on the pill in life? Because that gives us clues. And what's the risk of having a trial? Because if it doesn't work, then actually definitely the risks are outweighing the benefits. But if it keeps someone exercising, in the workplace, sleeping, in a relationship, then that's what we've got to look at, not the isolated risks. And also putting it into context, if we're really worried about hormones, and then, you know, HRT, high dose estrogen, 300 to 400 good absorber on bloods. Peaks of estrogen at ovulation are in the thousands, 2,000, 3,000, 4,000. So look at the dose of estrogen compared to what this peak is, and what benefits could it give someone for well-being.
Yeah, I guess because there's a little bit of a buy-in time for looking at symptoms, that can sort of be a bit nerve-wracking as well if you're prescribing so early on. As in, is this going to work? And the patient might not feel like it will work. Yeah, I guess it's an interesting one when people are coming in and asking for it so early on. But you're right.
I think
should be looking at
why are they asking for it?
Yeah.
Because, you know, like I have definitely said to some women, I just don't think this is hormonal. So that's why I don't think hormones will help. So for this, I've made a course about kind of walking through what estrogen does and progesterone does, and a leaflet of like the hormonal journey. So looking at puberty, reproductive life, tolerance of the pill, because the more of these kind of red flags, the more indicative that the symptoms could be improved by hormones. And if perimenopause hormone changes occur from the mid-30s onwards, why are we waiting for someone to not be working and to be on mirtazapine and lithium in their late 40s and early 50s, when we could be using hormones appropriately. And I think it's about being aware of it. Like, I think, I'm really fortunate, in a kind of probably sadly sadistic kind of way, that I have been referred patients from psychiatrists, from liaison psychiatrists, from surgeons who are on this concoction of medications, and they're like, is it hormonal? And then with these little tweaks, they get better. And that's where I just feel that, like, I'm really privileged to see this, and we all need to just be a bit more aware of it. Because it's pretty incredible when you get someone on the right hormone treatment and they're like, I just feel the best I have in 20 years.
There's a couple of people who have just touched on, and I know this, you may not want to talk about it, but testosterone gel, the use of testosterone gel. Yeah. So should it ever be considered? Do you want to have a little chat about testosterone gel?
Once again, it's about individualization, and I think setting realistic expectations. If it's only licensed in Australia for libido in the post-menopause. So that's what I always go in with. And I'm not telling you I'm not going to prescribe it for you, but this is what it's licensed for. And then I figure out, why do they want it? And what are the potential benefits? And have I done everything else? Because actually, if somebody doesn't love their partner, or is working opposite shifts, and isn't going to be aware or try and make the most of increasing libido, and that's the only reason they want to have it, then the benefits aren't going to outweigh the risk. You kind of need to use it in conjunction with other things. And then, the data does say it doesn't improve cognitive well-being. But I think that if you ask people, then there's a cohort of women who it really does. And that's where we need to have some more guidelines and confidence to make individuals confident to prescribe it. And when I do prescribe testosterone, and I'm confident in prescribing it, but I'm also really confident in counseling women and setting people up to succeed and monitoring them. And, if you go too high, then it's irreversible, the impact of high testosterone. So I think we've got to, we need more support as a collective and as a community, and the data's not there. So I'm not sure where that will take us yet. But a lot of the time, I think patients want to be validated and listened to.
Fair enough. Thank you very much for touching on that. And just one last question. So in terms of using the oral contraceptive pill or hormone therapy, what would you recommend would be better in those early to mid 40s, when there's just the start of the perimenopausal symptoms?
I think it really depends on the individual. If they've been on the standard combined pill, they're busy, they've got heavy periods, it's worked for them before, why not do that? Some people, I do it for 6 months, some a couple of years, but I do, I want to get them onto the safest preparation in the kind of, in the transition. Some people feel better on the pill than HRT. So that's also, if somebody feels really well and they've got a busy life, do we want to rock the boat right now? I do also look at going to safer pill preparations. So I often use pills like Zoli and Slinder. And so, yeah, it's really, really individual and figuring out. And, sometimes you get it wrong. I've started people on the pill thinking that, periods are awful. And actually they felt rubbish on it. But I think, I always say to people that hormones generally, in 80% of people, I don't know, I'm just making up that number, by the way, progesterone helps us sleep and makes people sleepy. But that means there's some where it does nothing. And then you've got some people and it makes them have insomnia. And you just so I think it's a case of being really open-minded and problem solving when you're faced with these situations. But we've got to, have the time and the infrastructure to be able to do that. And this is where I think we need to like, you know, and I'm excited that Pharmac supported this, and I recognize the need for education, because we need to be able to have education and work together to be able to optimize our patients more, because a lot of these are just new concepts that we are kind of exploring with our patients.
Yeah, it really just harks to the fact that it is a totally individualized patient plan, right? And you want to look at what's going on.
Yeah.
So that is all we have time for tonight. And I just want to say it was such a privilege to have you speak with us again. And we always love having you on the webinars. I really appreciate all the resources that you shared with us tonight. And just a huge thanks again to Pharmac for supporting the delivery of this update. Thank you to everyone for joining us tonight. Have a lovely night, everyone. Ka kite, and thanks again, Sam.